Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your facilitator for today's session. Today we have with us Dr. Nestor Praderio, and he's going to be talking about Alzheimer's disease and behavioral disturbances. Before he gets started with his presentation, let me tell you a little bit about Dr. Praderio. Dr. Nestor Praderio was born and raised in Argentina. He is a graduate of the University of La Plata School of Medicine and completed his residence in psychiatry at the Yale University affiliated program of Connecticut Valley Hospital in Middleton, Connecticut. His special interest is focused on geriatric psychiatry. He is a consultant of many nursing centers and assisted living units in South Texas. He is also the founder and president of Face to Face, which is a nonprofit organization and Alzheimer's support group. All of his time dedicated to this organization is volunteered, and it includes monthly meetings in which he speaks to family, caregivers, and clinicians, the annual Face-to-Face Festival, and a yearly Coastal Bend Walk for Memory. Dr. Praderio, thank you for joining us today.
Thank you, Glenda. Good morning. Good morning to all of you. Happy to be with all of you today. We prepare with Elsa and Marianne a presentation that we thought this is going to be beneficial to everyone who care for individuals who have dementia, specifically the behavioral disturbance. We will start defining, if it's possible, to have a better understanding what is dementia. If we go on the street and we interview individuals and you ask what they can tell you about dementia, the first thing that they will say is a disease, it's a disorder that have memory impairment. Perfect. That is a good definition. But it's not just memory impairment what defines dementia. Is memory impairment with at least one of the following. The individual have aphasia, and is expressive, and is called word finding difficulties. This is characteristic, anxiety provoking, and very difficult to understand from third parties or people caring for them. They may have apraxia. This is difficulty with a small neurological movement. They cannot wind their watch any longer. They cannot sometimes accommodate tiny things. And in general, when they become apraxic, sometimes they cannot coordinate well to use different mechanisms, specifically microwave, specifically control remote control, and those kind of things. And finally, they may have a nausea, and a nausea stands for difficulties in not having the ability to name objects. And you show to them, what is the name of this? And they will say, well, I know that you use this to write, but they cannot say pen. Therefore, the memory impairment with the association of these plus executive function, the functions that allow you to plan, to organize, to make a decision, to use judgment, are all deteriorated. Therefore, dementia It's a deterioration of the mental function. It's more severe than just when some individuals say, you are getting old, that's the reason. Getting old is one thing, having dementia is another. It's impacting in your activities and is making you dysfunctional, and it's progressive. It's a disorder that's from the beginning to the end, progress chronically without stopping. And it's a disease that until today doesn't have a cure. And how we define memory? Well, we have the ability to enter information and store it in our brain, as well as we have the ability of using any type of memory to store and then to retrieve. Because if I talk about sensory memory and I have the scent of a flower, regardless if I am in the Caribbean or in South Africa, the sense is going to be to store, and 10 years later, I will remember and be able to retrieve the sense and have memory. That's happened with sensory short-term and long-term memory. One of the most common dementias in the United States is Alzheimer's disease. And Alzheimer's have a prevalence. This I'm trying to show you some numbers in here. And here we are with approximately 5.6 million people with the disorder. Expecting this by 2050, we will have 13.2, 13.5 people with the disorder. Now, if you pay attention to the colors, at the decade of 85 is where more cases occur for every 100. Therefore, in these 3 blocks of decade of year, 85 and older are the most rapid to decline. And then let's have an idea of what type of dementia we have in the United States. And like we always say and repeat, 65% of the dementia in USA are Alzheimer's disease. Therefore, with our eyes closed, the most common dementia in USA is Alzheimer's disease. And then it's being followed by a group of vascular and a little Alzheimer, but there's a group of vascularity, and there is 5% more of vascular dementia. Therefore, both of them together make about 15 to 16% of vascularity problem, individual with a stroke, hypertension, diabetes, previous aneurysm, difficulties in circulating blood on the brain. To this side, we have frontotemporal dementia, progressive supranuclear palsy, the 7% of Lewy body dementia. We have so many difficulties in control behavior, Parkinson dementia, and there is a form of Alzheimer mixed with Lewy body dementia. This occur up to 5%. But those are the definition of dementia. Now, what happened with us? How we start noticing that something is not working appropriately? There is a little of memory loss at the beginning, very much protected and resisted by the individual. The individual will start taking little notes, writing down a little piece of paper in order to memorize. But few hours later, they don't know what they wrote. They will show up with telephone numbers. And when you ask to whom they belong, they don't remember exactly why they put it down the phone and who gave it to them. Some difficulties in performing familial tasks. My patients and the family come and tell me, well, my father is horrible for the last 3 or 4 months with the television. Oh, you don't believe, Dr. P. He take the control remote and just make a mess directly. He have more difficulties in naming things. The other night, he got up to use the bathroom during the night, and then he got lost inside the house. He called me, and he was sitting in the living room, just waiting for me to guide where the bedroom was. The judgment declined, and he started cracking jokes that Dr. P are inappropriate, but he just said it in front of people. Joke that Daddy never will say in front of people. We start noticing more abstract thinking. What is this? Well, abstract thinking is how I'm going to calculate if I am going to pay the bill, how I'm going to manage writing a check, adding, discounting, accommodating to whom. Therefore, we start noticing those initial clinical representation. And in general, when they start concerned about what is going on with them and cannot express it very clearly, is when they lost interest, some lack of initiative, they remove from the center of the conversation, they remove from usual activities. Therefore, you invite your mom and say, come with me, we are to so-and-so to celebrate the little kid, the 6 years old birthday of Peter. And your mother go to the birthday that there are people different age and noisy, and she attempt to sit to the side. She find a chair that is comfortable just outside of the noise, trying to prevent anyone to come and ask questions that may be discomforting for them. And today, I decide to show you, beside the clinical component of the disease, some of the behavioral disturbance of the disease. Therefore, we may have disturbance of psychotic symptoms, and I will explain it to you. We may have apathy, agitation, irritable affect, inappropriate activities, and depression. And for each one of them, we will touch bases and to talk about this. What is the agitation? How the agitation present? Well, present with psychomotor, walking a lot on the process of being agitated, wandering, specifically, we have individuals that like very much to look at the exit signs in any building. Therefore, they wander, they are exit seeker that we call, and they look where there is an exit sign and boom, they go. Therefore, wandering can associated with escape, with a wall, with difficulties in managing those individuals. There is non-directional pacing. You see very much at the nursing home, individuals, they just go in circle and circle, and sometimes come another individual and pace with them. Therefore, you can see 2 or 3 of them pacing. They didn't organize this walk, but they walk together. And they increase the verbal output. There is a relationship in all of the research. The youngest is the individual with dementia, the higher the level of agitation and how things happen. The depression, if you picture a nursing home, between 25 to 50% of the individual under the roof have depression. And specifically, a bigger amount of depressed individual when they carry the diagnosis of dementia. Some of them have increased motor activities and they become irritable and agitated. Others decrease the participation, change with insomnia. They attempt to sleep during the day, and they are awake and with disturbing behavior during the night. In general, depression have a clear correlated with mild cognitive impairment. I am sharing with you is with the beginning of the disorder, when the initial part of the dementia occur, the most acute depression occur. We don't know exactly if depression at this age and with dementia is a depression that has been pre-morbid to the disease, or is a depression provoked by the initial dementia. But anyway, we need to treat them. What we do with before I go this, let me talk a little about what happened with psychosis. Psychosis is characterized and defined as a lack of contact with reality. Therefore, we may have psychosis when we have delusions and hallucinations. Both of them are not reality connected. The hallucinations in dementia become very, very suspicious, reaching the point of paranoia. They are insecure. They believe the others are trying to hurt them. They wonder very much with suspicions and paranoia about the loved one. The man believes that the wife go to the supermarket because she is cheating with someone, the cashier, the register, or the wife. The husband proposed to bring some caregivers to help the wife at home, and she resisted because believed that those are the girlfriend or the husband. Therefore, there is a projection, paranoid projection, and all of these. And males are more characteristic of accusatory behavior. like my wife and my daughter are trying to steal my money. They put me in a nursing home because they want to sell my drug and they want to just get my money out of the bank. When females are more sensitive to properties, to specifically, they come over here and they stole my jewelry, my clothes, my shoes, or they abandon me. There is a constant, almost deep paranoid sense of being abandoned, leaving behind. The delusion, the hallucinations occur more visual than auditory. And we need to be careful because sometimes one of the dementia who have the higher level of visual hallucination is Lewy body dementia. And they are very scary, very disturbing. There are people chopped up in pieces. There are blood all over. There is a snake on the bed. But we need to be careful if the visual hallucinations are not associated with auditory hallucination, because the combination can be dangerous. When I say visual and auditory is they will show you something and then they may comment you in the act, telling you, do it, move, do it. And they show you a knife and then the voices may say, cut yourself, and you cut yourself. Therefore, we always trying to understand if the visual hallucinations talk to them, because if they talk to them, they find that they have auditory hallucination too. And you have to define the clinical situation differently. Well, how we assess the individual, they come to your office. Historically, the family will decide to send a patient to me. Through the years, insurance company has been making this a little more difficult because many insurance companies don't allow just to make your own decision and go and visit a geriatric psychiatry. Some of the referrals have to be channeled through the primary care physician, and you have to go and talk to the primary care physician. And in general, my experience in South Texas, they are going to say yes, and we will send it to Praderio. But I hear from others, colleagues across the country, that sometimes is creating a little resistance, and the patient are not being seen with the speed that will be appropriate for this case. When the patient arrives, we're trying to collect the maximum amount of medical history. If they have any imaging study, CAT scan or MRI. I personally interview the patient, and then I introduce a family member that come with them with the permission of the patient. Because in order to collect social history, you need more than one voice, and we review that. Then we do a mental status examination. And one of my employees, one of the nurses, do a mental state examination. This is a test of memory, as well as physical self-maintenance skill. If it's necessary, we go with neurological visit consultation. If I found that there is any pathology that may need neurological support, I will just pick the phone and make a referral to the neurologist and to see the patient. If patient have abnormal movement, A patient present with Parkinson, never diagnosed before. A patient is in status post-stroke and have difficulty with movement. In general, I will consult with a neurologist. We will do EEG and brain scan and laboratory studies looking for thyroid function tests, level of vitamin B12, and different studies that we check in order to be sure that we initiate a good evaluation. Then when we have the diagnosis of work, we have to start talking about what are the stages of the disease. And this is applicable not just to Alzheimer's disease. This can go with vascular dementia, Lewy body dementia, or Parkinson dementia. Other dementia have the same type of stage. Well, the initial or mild stage take approximately 2 or 4 years since diagnosis, but we need to be careful because diagnosis sometimes occur in an intermediate stage. Sometimes my patients come to me when they already finish with the initial or mild stage. And if you want to hear, the patients are not coming to me for loss of memory. They are coming to me for increased behavioral disturbance and no possibility of management those behavior at home. Therefore, they come to see me when they already have 5 years of a demented process. But the stages are initial, mild, intermediate, or moderate, and an advanced severe disease, the shortest one. The intermediate and moderate stage is the one who carries the most disturbance of behavior. The initial is they become repetitive, they ask you the same question, or they tell you the same stuff in repetitive way. They get lost easily. Specifically, they lost interest in different activities that he previously enjoyed, cross-person, individuals who enjoy a lot reading the newspaper. You ask the daughters of the son, do you notice anything different with your mother and with your father? And I remember a son who was bringing the mother from Kingsville, Texas. He said, "Doctor, I don't know why mom stopped reading the newspaper. There are 4 or 5 newspapers on the porch, on the entrance, that she doesn't go and pick the newspaper anymore." Yes, it's a loss of interest. She noticed some difficulties in reading. She lost some track of the reading. She wasn't concentrated to understand. Therefore, she abandoned the activity. They lose things frequently. They have difficulties. Female has difficulties around the kitchen environment, microwave, preparation of different dishes because they have difficulties specifically from executive function and following a recipe. They has been cooking with this recipe for 30 years, but suddenly now they cannot accommodate it and plan it in order. Therefore, they repeat some component and they miss other component. And they get in trouble and they get scared and they have some personality change and they really isolate, and there is a lot of depression and anxiety this start occurring. Now, when we go to the moderate stage, this characterizes the disease by a more confused stage. Therefore, there is confusion in dressing and simple activity, or in forgetting that they put a shirt and putting the second one on top of the first one. And they are happy. They go around with two shirts, one on top of the other, without saying anything. Here are the false belief or belief they think are real when they are not, or the opposite may occur, but this is the center of delusions and hallucination. This stage requires more supervision. In this stage, I don't want them taking their medication unsupervised. At this stage, we need to be careful that they are going to drive the car. They have psychomotor hyperactivity. Sometimes they become agitated. And this state is the most common stage of the illness. This individual end up going to a 24 hours a day caring center or nursing home or assisted living unit, because define clearly this is the stage that there are more difficulties for taking care at home by caregiver or family member. It's something that we need to take into consideration. And the advanced stage is not understanding. You cannot use command anymore. They don't recognize any of the family members. Maybe one day the husband look at the wife and say her name. They look at themselves in a mirror and they punch the mirror because there is another person that is scaring and looking at them, and there is no recognition of any family member. And as the advanced stage, they start acquiring a more fetal position. They eat very little and they become sometimes agitated. Well, if we have been talking about behavioral disturbance and the disease, a little here and there of having a better understanding what is dementia. Would be nice to say, I don't say how to treat the illness because there is no treatment. But well, let's go and share some management of the illness. We don't throw the towel like years ago and say, well, there is nothing to do. What are you going to do with this? Let's go and attempt by knowledge, by research, by studies, by clear development of treatment plan, do something to manage the disorder and give quality of life to the individual. We can start with the initial. This is the pharmacologic, and there are some medication that we use. The behavioral intervention, this is part of what we are doing today, because how we are going to intervene if we don't are able to recognize the behavior. Today, we are learning more about behavior. There will be a day tomorrow that we will learn about how to intervene to decrease those behaviors. Family support and education is what we are doing to share information, and an overall integration of modality and one treatment plan. Communication between the primary care physician, the person who sees the patient here, me with family members and the patient, always triangulating with integration of modalities in order to accommodate an appropriate treatment plan. Well, in general, the frequency in which one you review the plan of treatment is very important. When I stabilize my patient, I adopt a frequency that's worked well for the majority of them. This is 12 weeks, every 3 months. A good communication between my office and the family if it's needed, and if they need some change, we will respond with a message or with a telephone conversation. But in general, the 3 months give you a good amount of time to evaluate the chronology of the illness, meaning the amount of decline that the patient have in those 3 months. If there is no decline, you and the family and the patients are happy because you are creating a partial stability on the process of decline. We talk a little about initials, conversations during the review of treatment, how they are sleeping, how they are eating, if they are swallowing well, if they walk well, if they are not falling. We talk about safety issues. We talk about, I think this can be very beneficial to caregivers too. And many families bring the caregiver together with them because they want them to be exposed to the conversation. But it's important to review. It's very, very important to review the treatment plan. We use the time of the visitation to share information. I learned a lot from my patients and family or caregiver about other resources available. They learn from me different methodology to adopt. And if we have any medication that we are going to change, I give them information about what is going on. And I alert them through the process of decline to move ahead and do some counseling for legal and financial issues, not let the time to catch up and don't authorize of the patient won't have the ability to sign papers for power of attorney or different type of legal papers. And everybody is aware, coming with the family, that we have our monthly support group and we offer information. Well, Glenda, we are going to conclude. We are going to say why an early diagnosis is beneficial in treatment. Again, I repeat, it's not a curative treatment. Until today, there is not a cure for Alzheimer's disease. The early diagnosis allow individuals to prepare the management with anticipation, to be alert, to have some time to educate yourself, to have a better understanding what are the stages of the disease and what is coming ahead of you. There is not a crystal ball prognosis that you are going to have, but at least you have a better understanding and a better preparation to deal with. You can take advantage and target what are the cognitive deficits, including memory, aphasia, executive function, and the non-cognitive deficit, because some demented individuals are coming charged with medical problems. They may have a vascular dementia, but they have 2 previous strokes, and they have difficulties moving, or they have wounds on the back, or they have a need for different alimentation, or they have an NG tube, or they have a PET tube. Therefore, we need to balance what is cognitive and what is not cognitive. And specifically, I like a lot to balance supervision with meaningful activity. Specifically, I will share with you what is the meaning of the you supervise when you believe this is necessary, but you allow your family member of your patient to do as much as possible in their own, because this is what conceptually make them to feel good about themselves. You don't allow the patient to do what he cannot do, because this is stressful, create anxiety, discomfort, irritability, and it's difficult to manage there. It's to expose them to failure, but you allow them to do without taking over what they can do. Therefore, you pay attention before feeding them how much they can do on their own. Because, if we are going to adopt the rules of society, they cannot take the fruit with their hand. They need a little fork. They need it. Well, you are the one to balance this level in order to supervise when it's dangerous and give some freedom for the patient to feel better. We educate, counsel, and advise regarding treatment intervention. We don't feel a bunch of losers when we have to change our treatment. We believe the things will go well, and then didn't go well. We achieve clinical plateau, meaning the patient visit in 3 months and is doing so good, and is coming in 6 months and is doing so good that we feel just to dance a little in here, because we have to enjoy those clinical plateaus in which one the chronicity and the decay is not so rapid. We talk about prognosis. I always teach individuals that are transition between stages. Between the initial and the moderate, patients have more irritability. They answer more. They are big mouth answering back. They are more resistant. They pretend to be joking, but they are not joking. They have less executive function. They become more inappropriate. Those things occur between initial and moderate. And between moderate and advanced, what occurs is the overall confusion. There are some random, but a confused environment that deteriorate the level of function. Well, thank you very much, Glenda. We will stop in here. I will be very excited to have questions. Sure that there are individuals wanting to have questions, and we will see what answer we have, and I will love the participation.
Okay.
If you give me 1 second,
We will give you 1 second.
1 second. I am going to do something that is not academically recommended, but is heartily recommended. I am going to say hi to Mark Aguirre. I haven't seen Mark for a few months and I was missing him. Hello, Mark. Good seeing you around.
Hello, Dr. Praderio. How are you, sir? I apologize. I took a hiatus, taking care of my mom, so I am back.
Thank you, Glenda.
Oh, absolutely. Glad you're with us today, Mark. So if you have questions, comments for Dr. Praderio, let me look at my screen a little bit differently here. Here we go. You can unmute your microphone and I will call on you by your name. I see we have a couple of people that have telephoned in, and you can press *6 on your telephone. That will unmute your phone and I will call on you by your area code. The chat box is open. If you're more comfortable putting a question or a comment in the chat box, you're welcome to do so. And we will get to that as soon as we possibly can. And just as Dr. Praderio says, we'd love you to join the conversation. He's open and wanting to hear from you. Jim says the impact of computer media versus TV, some better are things to avoid. I guess this is exposure to someone who has Alzheimer's disease, Dr. Praderio. Should they avoid TV?
Well, it's important not to overload the brain of individuals with cognitive deficit. It's important, but minimizing the surrounding noise, the loud music, or individual that in certain or material that in certain form is disruptive for them. Therefore, television, we need to be careful. And the initial stage, they can follow and they don't get agitated. But you will notice that they will stand up and leave the place and take a walk and go into the kitchen. And that is a marker for you to know this, to be in front of the television is not the most recommended thing.
Thank you for that answer. Yeah, I can see how in the beginning it might be okay, but let's see. Stephanie says tools for responding to and managing the patient's feelings of panic or paranoia. How do we as a caregiver deal with that?
Well, we are going to divide the question because panic is product of anxiety, nervousness, almost reaching a point of discontrol, the not being able to stay together and screaming, yelling, misbehaving, irritability. And all of them have to be dealt by appropriately intervening. A little drink or something to eat. It's incredible how good calming effect have an individual. Mom, let's go a little juice and I will give you a cookie and sitting here. Why we don't move over here? I give you some water and I sit with you and you explain it to me. A sense of intervention this will dedicate to them, correct anxiety and panic very much. Now, take into consideration, anxiety and panic can be product of what they don't say, what they cannot share with you. And what is the worst thing that they cannot share with you? Is to tell you that they are in pain. All we think that your demented family member might be on pain and they cannot share with you because they don't know how to express that. Therefore, sometimes one Tylenol is better than 100 interventions because we are all we have bone hurting, we have arthritis, we have different pain, we have headache, and if we cannot express, it's very difficult. The second part of the question, she named psychosis. That's different. Psychosis are delusions and hallucinations. And if the patient is saying, I don't want mom going to HEB because she is dating the manager of HEB, and this is not true. Well, we are in trouble. We will need to talk to Dr. Praderio because a little of an antipsychotic medication will make peace between the home and HEB and the managers and everyone. But that's different. This is a psychotic episode. And remember, occurring more during the moderate stage of the illness.
Okay. Twyla, you have your hand up. You have a question for Dr. Praderio?
Yes, I do. I really enjoyed the presentation. And I am caring for my husband. He's 66 and he's been diagnosed with dementia about 5 years ago. So when you're trying to get him to take a shower, to keep him from getting agitated, what are some suggestions?
Oh, Twyla. Twyla opened the chapter of personal hygiene. And honestly, have many parts. We will give a little of a mixed menu to her to help her. Number one, why someone being demented, clean all of his life, wanting even 2 showers a day, suddenly is a chaos? Why? Well, it is because life is different. Because now I have a dementia and I have visual spatial deficit. And the water from the shower is not a shower anymore. It's a waterfall that is coming to hit me hard. The sometimes I don't even want to think because I believe this make me throw back on the floor. Because there is such a distortion with what is going on around that therefore I don't want it at all. Who care about no showering? I don't want it at all. Therefore, Twyla, the day is, what are the best hours of the day to do personal hygiene? Morning time, not evening, please. What is the best time on the morning? After breakfast, nice breakfast, happy, there, a little fruit, your muffin, looking, your bacon, boom, and we get ready. And how we get ready? You prepare in a chair the clothes that he is going to wear. You put the pants, the shirt, underwear, in a pair of socks, and you say, look at daddy, look at mom. This is we have ready of fresh, new, you can smell it, fresh, new clothes that we are going to use, right? Because you help them to build a sense of pertinence, not taking off the clothes without knowing who is going to help them to dress up? Because they already fail with this. They already having a shirt in their hand and not knowing how to put it on. Therefore, don't scare me anymore. Tell me that you have everything ready and that's go well. And going to the shower, go with a chair with wheel, a shower chair, and go with a hand shower. And use washcloths, use shampoo. Never start a fight in shower shampooing. You can dry shampoo, having a conversation with your father or your mother. Dedicate the time on the shower for personal hygiene. You use the washcloth, you give another to the person, you take care of this part and I take care of this, and always with the hand, nothing coming from up there, all the water in here. That's a kind of a little package for Twyla.
Was that helpful, Twyla?
Yes, it was. Thank you so much.
We've talked about TV and media, Dr. Praderio. How does music play into, working with people with dementia?
Excellent therapeutic tool if we manage appropriately. It's impossible to have an 82 years old demented individual listening to Bad Bunny. Therefore, you have to accommodate what is the component of therapy. Therefore, you need to know what were the wishes and what music the person like to make it as a background, not very loud. It's a super calming effect. And there are good studies showing the upper channels of all memory. Therefore, if you put background music and you sit and you do reminiscence, it's a wonderful package.
Great. I had heard some people talk about when Twyla brought up the personal hygiene that they put on some soft music or something like that, and it seems to calm a little bit. So I wanted to ask your opinion on that. Let's see, Blanca put in the chat box, in the beginning stages, what are some recommendations to help deter disease progress and or minimize behavioral outbursts and improve quality of life in an independent living community? Okay, so she is a social worker and a service provider, and so she's asking this, I assume, Blanca, for the people that you're caring for, but some recommendations to deter disease process or minimize behavioral outbursts.
Yeah, specifically for her role in being a social worker too, we don't say that we detain or we don't say that we cure. We're trying to slow down a little the process, or at least to take away some of the behavior that are extremely disturbing for the individual. And those are level number one is to be sure that we are going to accommodate nutrition appropriately. That we are not going to struggle because they don't want to eat meat anymore, because we can use protein powder with an ice cream and make a wonderful drink and thus have protein. We need to be sure that they are going to sleep, because sleep disturbance, the insomnia create deterioration, rapid deterioration. And we are going to be sure that we have a good complementation with the PCP, not to have associated medical problem going on with the patient, like diabetes, COPD, any other disease that decompensate the physical part of the patient. The rest, we can use creativity. There is many activities available nowadays, from different type of games that they can play to do some art and craft and work with art and craft. There is nice because they decline in the aspect of reading, but they love if you can do a newspaper club or a book club, in which one you pick some democratically what they want to have, and you read it to them, and you offer the group the possibility to make comments about and to revive some memory if they read the book before or if they hear before. There are important things about distracting them. Once a week, when I was running the unit, I used to have something that is interesting to them, and the just cut a little the routine. 1 week, I invite someone who have a human support dog and come to visit the unit. And the dog came, and my patient will have each one of them a little cracker to give to the dog. But the comment after the dog left is incredible. The dog that they have in life, the good dog, the better dog, the tall dog, wonderful. Once a week, I will invite a group. This was here in town, and one of them will come. One will play saxophone 1 week. The other will play guitar. No longer than 20 minutes, but it was just a party for them. It was incredible that someone can be a musician in front of them, fulfilling in just giving life to the environment. Therefore, those are the forms, but you cannot do this if someone is psychotic. You cannot do this if someone is not sleeping. You cannot do this if someone is over-medicated and sleeping all the time, that someone is playing music. Therefore, there's ways and ways.
Yeah. A couple of other things. I know we've gone a little bit over, and but we'll take care of what we have right here, and then we'll conclude. Back up to Blanca. She wanted to know, are there some indicators of when someone needs to transition from independent living to an assisted living or nursing home? And how can you facilitate that transition, which is difficult for sure?
There is a presentation that I give annually. Keep in mind and follow us, maybe you will get it. In general, came around September, and it's planification for nursing home placement.
Okay.
Well, the answer, quick answer, is an issue of safety. Therefore, you need to take your heart and put it on the refrigerator for a while. And the definition is risk-benefit. Pure risk-benefit. Your mother has been falling at home. Your mother has been missing medication at home. The helper that you have at home are not performing appropriately. Your mother twice was found on the floor, and go with safety issue. Your mother walked out of the house unsupervised. Your father took off, and the police bring them back to the house. All safety issue versus benefit. And the benefit will be to have a supervised environment. And your heart is on the refrigerator, please. Don't move it out of the refrigerator, because you move your heart out and you make decisions that are heart connected. That is no risk and benefit. And then you go and visit different facilities, trying to see what is the best. And if you marry a facility and 3 months later you don't like it, you go and change your mother to another place. That's what we do with our car. If we don't like it, that's what we do with something else. Therefore, conceptually, it's a risk benefit. A fracture of the hip should not occur if we have resources to prevent it.
All right. Keith wanted to know about, and I think this is the new medication that's just come out for treating dementia, Leqembi. Do you have some thoughts on that or information?
I have some that I won't share because it's too new and I need my own understanding.
Yeah.
But honestly, I recommend for you to slow down your expectation is your craziness, because it's not finally a study. It's going to be injectable, an infusion. It's going to be very expensive. And my personal concern have some side effect that I don't swallow at all. Mm-hmm. Therefore, there is a group of us, geriatrician in USA, that they were not happy with the approval.
Mm.
But we are very open-minded to see what is going to occur.
Yeah. I know as an individual, if I watch the TV ads and they tell you about a medication and then you listen to all the side effects, I'm going, well, yeah.
Yeah,
I don't think I want to take that.
right?
For sure. That's some
Yeah.
scary things. Okay, Mary Ann, you had some announcements you wanted to make. Please go ahead. Well, she reminded me that she had some announcements, but
Mary Ann,
okay. Yeah.
I'm
You-
sorry, I was talking and talking and I was muted.
Okay, go ahead.
Okay. Well, thank you everyone for joining. If you have more questions on the same subject, Dr. Praderio will be doing his face-to-face support group on the 4th Wednesday of the month, which is July the 26th this month at 5:00 p.m. And I have put the phone number in the chat. If you need the link, just call and leave me a message and I'll call you back or we'll send you the link. It's the 361-826-2343. And again, that's a support group. That's the one Mark usually joins us for. So thank you for joining us, Mark. And so we'd like all of y'all to attend. We'd also like to let y'all know that we're very happy to announce we have a date for our face-to-face family and friends caregiver festival that Dr. Praderio had been doing for many, many years and had to stop due to the pandemic. This year, it's going to be at A&M University on September the 20th. Details are still pending, but we will also get those out to you if you request for the information. And the last thing is our Walk from Memory, November 4th at Water's Edge Park. You can join that one virtually. On the face-to-face festival, we're still working on it, and we will let you know if that's going to be hybrid. But thank you once again, Dr. Praderio, for a wonderful presentation you've done for us. We really appreciate you.
Absolutely. I love being on with him. In a few days, you'll receive a follow-up email if you register for the call today, the session today. And in that, you can give us your feedback on what you think about this session. And I always encourage people, if you have a topic that you'd like to hear about, we haven't presented or you want to hear it again, please let us know when you get that little survey. And I'll include this information that Mary Ann just shared in that follow-up email for you so that you'll have that at your fingertips. Dr. Praderio, thank you so much for joining us today.
Thank you, Linda.
Look forward to seeing you next time.
Thank you, all
Everybody,
of
take
you.
care. Bye-bye.
Bye-bye.
See you next time.
Adios. Thank you.